Good morning. It is indeed my pleasure and privilege to be here for the second annual conference of the POGS. The NOESIS 2.0 is all set to exceed all the expectations that we had from this conference after the wonderful first edition of this conference. Let me thank the FOXY team led by Dr. Shanta Kumari, the Vice President, Dr. Kavita Bapat and FESI, Secretary General Dr. Madhuri Patel, Dr. Rishikesh Pai, the President-elect, and of course, the wonderfully dynamic, enthusiastic, and enterprising Dr. Mitra Saxena, who is the chairperson of the Practical Obstetrics Committee of FOXY. Thank you very much to the POGS and Dr. Mitra for inviting me to give this presentation, along with the KFOG team led by Dr. Ajit and Dr. Venugopal. I must thank Dr. Kunju Moeddin, Dr. Abdul Wahab, Dr. Mani, Dr. Mamtaz, Dr. Sanesh Kumar, Dr. Jitendra, Dr. Sharat, Dr. Ashwati Kumaran and Dr. Ashwati Govind, Dr. Reshma Sajan and Dr. Vinny, who have done such a wonderful job of putting this conference together. It is, of course, a pleasure and a privilege to speak in a session chaired by Shaijus, Priyankur, Dr. Gopinathan, and Dr. Ananda Mohan, alongside such wonderful speakers like Dr. Habibullah and Dr. Archana Basel. I am going to actually speak on the post-operative management of LSCS and the enhanced recovery after surgery, which can take place from this very common operation that we do in obstetrics and gynecology. But before I proceed, let me ask for your kind support as I stand for the election of FOXY for this current presidential year, a request I will reiterate at the end of the presentation. You know, sometimes I feel that unfortunately, cesarean sections, probably because they are so common that we sometimes take them for granted, are to a certain extent being demonized. They are being demonized by us being constantly told that we do too many cesarean sections. It is nobody's case that we do cesarean sections willy-nilly, but we also need to remember the wonderful operation that a cesarean section is. And as Carl Gustav Lenander said, embedded in the name cesarean section lies an aura of greatness, something elevated above the mundane, and it is indeed a name worthy of the operation, by which it is possible under certain circumstances to save two lives, otherwise destined indisputably for a certain death. For something which is as important, perhaps, as the surgery, and that is the recovery from the surgery, it is not surprising that there is a society. It's called the ERAS Society, and this society has a delivery guideline or pathway where a maternal-focused pathway for scheduled and unscheduled surgery starting from 30 to 60 minutes before skin incision to maternal discharge, with early recovery after surgery consensus recommendations being proposed. So what I'll try and do is take you through these consensus recommendations, but also add what we have learned over more than 2.5 decades of doing two cesarean sections in our practice. So this is part one of the guideline on enhanced recovery after surgery for cesarean section. It essentially says that you should have patients who are very well counseled, because well-counseled patients are both accepting of surgery tolerate the surgery well, and even recover very well from the surgery. There is something to be said about for how much time the patient should be NBM, etc. And I will talk about that a little later. But an element which is very important in recovery from surgery is how well that patient has been managed preoperatively or in terms of before she has actually gotten pregnant. So recovery does not solely depend on how you do the surgery. It of course also depends on the preparation that has gone into the surgery. So all the possible morbidities which could occur should ideally be addressed before surgery, or at least to the extent that they can be addressed even if the surgery is unscheduled. Within the preoperative preparations which cause enhanced recovery are these couple of things. Antacids and histamine H2 receptor antagonists can be administered as pre-medication, both to reduce the risk from aspiration pneumonia as well as to reduce the incidence of intraoperative and perioperative nausea and vomiting. One of the small tweaks that we have done in our practice, and frankly, I did this after I was called to help a colleague where IV ondansetron was given and the patient collapsed. Apparently, this is a very, very rare but not an unknown problem with ondansetron. So what we do now is that 2 hours before surgery, we give the patient an oral antacid and antiemetic along with a sip of water. It seems to work very well. We have been doing this for almost 2 years. And in those 2 years, we have never really had any cause to regret. Of course, it's quite important to remember that if you are doing the surgery under a regional anesthesia, you should ideally not be giving sedation to the patient before the baby is born. We normally try to keep sedation to a minimum even after the baby is born to ensure that the patient can breastfeed the child quite immediately after the cesarean section. Of course, there is really no need for any oral or mechanical bowel prep. And in fact, these guidelines seem to suggest that women can be taking clear liquids right until 2 hours before surgery and can have a light meal up to 6 hours before surgery. In our practice, we don't mind them having a light meal 6 hours before surgery, but we try to make sure that they have very restricted fluids after that. We always try to see that there has been an adequate amount of counseling which has gone into taking the consent for the surgery, and also try to have blood at least arranged at the bare minimum before we take up the patient for a surgery. In the intraoperative, it is of course important to give perioperative prophylactic antibiotics. One of the things that again we have tweaked within this is that test dose is of course always given, which should be given as a matter of routine, but we have stopped giving a bolus dose of the IV antibiotic. We always give the IV antibiotic piggyback, so we put it in 100 ml of a crystalloid solution and then give it slowly. The advantage of this is that if the patient starts getting some kind of a reaction to the antibiotic, you can stop the injection. By stopping the injection, you're going to reduce the amount of exposure to the allergen that the patient is getting, and it also gives you some time to react while the antibiotic is going on. I'm going to talk a little bit about skin prep and anesthesia in the next few slides. Temperature maintenance during surgery is perhaps something we don't adequately think of, but is quite important when you look at that patient's homeostatic milieu. We will talk about cesarean delivery technique a little later. Maintaining U volume here, both intraoperatively as well as postoperatively can considerably enhance the recovery of the patient and needs to be addressed adequately. And of course, a good amount of neonatal care, along with a lot of counseling and a lot of support for breastfeeding, is certainly quite important to make sure that the patient recovers well after surgery. After all, recovery from surgery does not necessarily mean only a physical recovery, but that the patient perceives the experience of that delivery as a good experience. For skin preparation, there is now good evidence to show that cesarean section actually can result in a significantly higher amount of surgical site infection, even for example, compared to colonic surgeries. Again, a small tweak that we have done for skin prep is that instead of starting the skin preparation after the spinal anesthesia is given, when everyone is in a hurry to start and you don't really wait for the time that is required for the surgical scrub, either beta scrub or any other scrub to act, we prepare the patient outside the theater, we scrub the area of surgery properly, we cover the patient, cover that area with the plastic sheet, and then bring the patient inside. What happens with this is that even if per chance there is a problem with the anesthesia and you really need to go in very fast, you are not going into a unprepared skin or a unprepared milieu for that surgery. We now know that perhaps a regional anesthesia is most suitable for a cesarean section. It is important, therefore, to tell your anesthetist that please use either a pencil point needle or at least a 26 gauge needle. The importance of this is to prevent both hypotension, high spinal, because the incidences of both of these go down, and most importantly, the use of these almost completely obviates spinal headache. And if you are talking of recovery, you will remember, for those who are senior enough, the huge problem that spinal headaches used to cause, or post-spinal headaches used to cause, somewhere around day 3, day 4, just when you thought that everything was going very well, the patient used to suddenly start complaining of something like a neck spasm and the fact that she was getting a very severe headache. Since we have shifted to the pencil point or very thin 26 gauge needles, we find that this problem is almost non-existent now. Besides that, there is an opportunity to administer intrathecal, either an opioid like intrathecal morphine or diamorphine preoperatively, and this works very well for the patient even postoperatively in terms of pain relief. In fact, your requirement of systemic pain relief given postoperatively reduces very dramatically after you use this drugs given intrathecally. One of our anesthetists actually also administers a small dose of steroids intrathecally. So he first gives the steroid injection intrathecally. That is then followed by a mixture of intrathecal morphine along with the local anesthesia, local anesthetic drug. And it really seems to work very well to reduce the amount of pain that the patient has after the surgery. Of course, you need to try and prevent hypotension or high spinal. And in case one of these two occurs, then really the best treatment is to deliver the child as fast as possible, because once you deliver the child, both these problems tend to settle down, the blood pressure tends to come up, and the patient starts to breathe quite normally. Of course, gentle surgical technique and tissue respect go a long way towards enhancing the recovery of the patient from surgery. Some of the recommendations are, in essence, to actually follow Joel-Cohen or modification of the Joel-Cohen's technique and try and make sure that you have as less use of energy as possible, because that seems to reduce the amount of pain that the patient will get after the surgery. Finally, once the cesarean is done, you need to take into account pain relief. We have more or less actually stopped using NSAIDs now for pain relief, we find that because we are using intrathecal morphine with that small dose of steroid, uh, paracetamol actually works very well. And I really like to use paracetamol post-operatively because it considerably reduces the incidences of any other kind of side effects. But of course, adequate pain relief is extremely important if you are looking at enhanced recovery. Early ambulation is also something that we believe in. Unfortunately, there is not enough evidence to show how early is too early or what is exactly the definition of early. We tend to mobilize the patients within the bed within 6 to 8 hours of surgery. We encourage them to sit up by making the bed go up a little bit, etc., move their feet around, and we actually try and make the patient walk as early as 12 to 14 hours post surgery, and the patient seem to tolerate it very well. Catheter removal is something which has always been controversial. In fact, most aspects of either doing a cesarean, indications of cesarean, or even post-operative monitoring of cesarean tend to be very controversial because it is such a common surgery and everybody has their own experiences and everybody thinks that what they are doing is probably the right thing to do because it has worked for him or for her. Recommendations say that you can remove the urinary catheter almost immediately after cesarean delivery, if at all it is placed during surgery. There are some articles which actually say let the patient pass urine before the cesarean, do the cesarean, and then let her encourage her to pass urine. Frankly speaking, I would be a little hesitant to do that. We catheterize all our cesarean patients, and we generally tend to keep the catheter in place for somewhere between 12 to 18 hours before we actually remove the catheter and encourage the patient to start passing urine. Perhaps we are a little old-fashioned, but that is our current practice. There is, however, mind you, evidence that says that patients where catheters are removed either immediately or patients where catheterization is not done at all also seem to actually not have any significant problems. We will talk about breastfeeding, support, and discharge in the next few slides. What has always been quite controversial in recovery and what seems to play a very important role in recovery of the patient really is post-operative NBM periods, post-operative nil by mouth periods. There really is no consensus on how long to keep the patients nil by mouth. In the early days, we used to keep the patients nil by mouth almost till they started passing flatus, or we would hear the bowel sounds very well when we auscultate the abdomen. But there is now more and more evidence gathering to show that many patients are fasted for long periods of time before surgery and also experience inappropriate regimes designed to wean them back onto normal eating and drinking patterns. It seems that the surgical stress itself increases the energy expenditure and protein loss, making necessary early nutritional support. And there is strong evidence that nil by mouth, at least for the period that we were classically following, is simply not justified. In fact, there are some interesting articles which are radiographic and physiological studies to show that the traditional practice of initiation of oral feeds based on auscultation of normal bowel sounds and passage of flatus and bowel movement is actually got no basis in evidence at all. In fact, if you control for severity of illness, patients who receive early and sufficient nutrition actually have a significantly shorter length of stay. So if you're going to compare early with delayed oral fluids, I think there is no doubt now that the early initiation of oral fluids, perhaps within 6 to 8 hours of surgery, which is something which we now follow, is actually associated with a reduced time to the first food intake, a reduced post-operative stay, in fact, a trend to reduce abdominal distension with no significant difference in compared to nausea, vomiting, time to bowel action or passing flatus, paralytic ileus, and even the number of analgesic doses. So early catheter removal, early mobilization, and early initiation of oral fluids and solids or feeding is actually a vital component of ensuring an enhanced recovery after surgery. Of course, when you talk about cesarean section or childbirth, you can really not talk about the recovery process without talking about breastfeeding. And the best practice seems to indicate that we should initiate breastfeeding within an hour of birth. In fact, as soon as the baby is born, is also a good idea, with exclusive breastfeeding for the first 6 months, continued breastfeeding along with adequate and quality complementary feeding after 6 months to 2 years or beyond. The first few days after a cesarean delivery are in fact extremely vulnerable periods for the patient, and they are vulnerable because there is a lot of unwanted advice coming in for the patient. People are very happy that she's had a delivery, but along with that happiness also comes a lot of advice, which frankly speaking, the patient could have done without. And therefore, it's very important that a conducive atmosphere of support is created for the patient. And before discharging the patient is taken into confidence and counseled extremely well regarding recovery. Of course, there is a case to be made now for standardizing cesarean delivery technique. I did point out that everybody does cesareans probably in different ways because everybody's had so much experience with cesarean, and whatever one is doing seems to be working well for us because otherwise we would not be doing that. But there is now a good case to be made for standardizing at least some aspects of cesarean and recovery from cesarean to make sure that this recovery from a fairly major surgical procedure occurs without any hindrance for the patient. So let me end by saying that the hallmark of labor management in the 21st century should be individualized care for the laboring woman with the expectation of a successful and safe vaginal delivery, together with the ability to intervene with a cesarean delivery if needed to prevent morbidity and mortality, and try to follow all possible protocols to make sure that the patient recovers very well. After all, we want to look forward with hope and not backward with regret. Thank you very much again for inviting me, Dr. Mitra, the POGS, Dr. Kunju Mohiddin, Dr. Abdul Wahab, all the FOXY office bearers. And let me again reiterate my request for your very kind support as I stand for the election of FOXY president for this current election year. I have actually developed a website. It's called isupportjaydeeptang.com. I believe it's the first time a website has been set up for a FOXY election. And if you go to that website, you'll be able to register your support for me. There is also a video blog section where a lot of my presentations are put up and which are really getting quite a lot of views. And there is also a Telegram channel over there. So if you click on that, it will lead you to a link where you can join a Telegram channel where I keep on updating whenever I give presentations or make webinars or convene webinars. Thank you again very much for inviting.